Welcome back to Save Your Thyroid with Jennifer Holkem, where we dive deep into the latest advancements in thyroid and patient care. Thyroid nodules impact millions of people, affecting as many as 70 to 80% of adults. If you or someone you know has been diagnosed with thyroid cysts, nodules, or even cancer, surgery may have been recommended. But is surgery really the only option? And more importantly, is it the best option for you personally? Well, the good news is that today, several FDA-cleared, innovative, non-surgical treatments are transforming thyroid care. In this episode, we're discussing the first to become available in the US, thyroid radiofrequency ablation. To help us break it all down, I have the honor of speaking with Dr. John Interlandi, a highly respected endocrinologist based in Smyrna, Tennessee. Dr. Interlandi has nearly 5 decades of experience in diabetes, metabolism, and thyroid disorders. A Vanderbilt grad, he initially retired after a long and successful career, but was drawn back to the field in 2021 to join Dr. Louisa Leal in her mission to bring thyroid RFA to more patients. In this episode, Dr. Interlandi will discuss topics like the history of thyroid nodule treatment, avoiding lifelong thyroid hormone replacement therapy, treating multinodular goiter, insurance coverage, and the future of this groundbreaking treatment. Dr. Interlandi, welcome to the podcast. I'm so excited to have you here.
Thank you so much for having me.
Thyroid RFA has been around for practically 2 decades overseas, and it's been FDA cleared in the US since 2018. However, it's still not widely known about in the medical community or readily available to patients. But it's kind of gaining traction and it's changing treatment options for patients today. But we're going to kind of back up from that and start with the basics. Share with us a little bit about how we even get into this conversation of treating thyroid nodules. We've kind of got to go back to the basics of thyroid disease.
Yes. So let me start with a couple of common misconceptions. The first one would be whenever a primary care doctor refers a patient to me and they say they have a thyroid problem, the first question the patient asks is it the one where I gain weight or the one where I lose weight?
Right.
Okay.
Right.
That's okay. My profession had a hand in promoting that misconception. What we're talking about today, which is nodular thyroid disease, is neither most of the time. It's neither weight gain or weight loss. Nodular thyroid disease is separate from what's called autoimmune disease. An autoimmune thyroid disease, which encompasses both Hashimoto's and Graves' disease. Those are the diseases that are associated with extremely high thyroid levels or low thyroid levels. And yes, they are associated with weight changes. But when we talk about nodular thyroid disease, and I'm going to use the word nodular thyroid disease instead of multinodular goiter. Another misconception is when you say goiter, patients immediately think that A, I'm going to have surgery, or B, I'm going to have this unsightly mass on my neck. The term multinodular goiter made sense when 100 years ago, when the nodules in the thyroid were, the size of golf balls or even the size of baseballs. But nowadays, because we have iodine mixed in with our salt, at least hopefully most of us use some of that during our adolescence, nodules are a lot smaller. So using the word goiter is kind of okay. It's what we're stuck with, but I prefer nodular thyroid disease because it's a little more specific. It doesn't scare people off quite so much.
Yeah.
So autoimmune diseases, we are not using RFA for that. RFA is used for nodular thyroid disease, which is essentially little bumps in your thyroid, and you can have lots of them, and they can still get pretty big if the conditions are right. Okay, so
Yeah.
Nodular thyroid disease is an interesting phenomenon. It's been around and recognized for thousands of years. There are even paintings from the medieval and even pre-medieval periods of people with these big goiters, and it almost looks like they have an extra head coming out of their neck. I mean, it's a very difficult to go around in life with a very large nodule or a bunch of nodules in your thyroid. They interfere with breathing, and even nowadays, if a nodule gets to say 3 to 4 centimeters, it can cause cough or interfere with breathing because basically your thyroid is stuck right onto your windpipe down there. So historically, there wasn't much we could do about nodular thyroid disease until the late 1800s when general anesthesia came in. Excuse me if I digress, but a little bit of history of this, I think
Yeah,
you'll
I think
find
it's
it
helpful.
interesting. There's not a major development until the late 1800s when people find that if you put people to sleep and if you know your anatomy, you might be able to take out a thyroid nodule or even the entire thyroid. So
Hmm.
the first case report in the United States is by one of the Mayo brothers in 1907, taking out a very large thyroid, which was full of nodules. That progressed because the Mayo brothers lived in Minnesota, which is one of the parts of the United States that's farthest away from the ocean.
Hmm.
So the people who got the nodules and the difficulty breathing were people in North Dakota, South Dakota, northern Iowa, and Minnesota. The Mayo brothers started doing thyroidectomies on these people who were choking, and they were remarkably successful in helping them. But this introduces the first endocrinologist that I know of in United States history,
Hmm.
which is they hired a guy named Dr. Plummer, who would evaluate the patients before surgery to make sure their thyroid level wasn't too high,
Hmm.
which would interfere with the anesthetic. And yes, sometimes you can get a high thyroid, especially if the nodules are really huge. And so he'd have to treat them medically with iodine and other solutions. And then he would take care of their low thyroid condition postoperatively.
Hmm.
And we'll come back to that issue, obviously,
Hmm.
about low thyroid postoperatively. But so
Hmm.
Dr. Plummer was working with them. So they developed a team approach at the Mayo Clinic. Both Mayo brothers and Dr. Plummer treated thousands of patients. And by 1920, they were pretty much employed full time, just taking out enlarged thyroids due to nodules. And so that's pretty much the early history, and things were happening in Europe around the same time and in a similar fashion. The
Hmm.
next development is the 90s when we have nuclear reactions. And suddenly we have nuclear reactors after World War II, and we have radioactive iodine available. So
Hmm.
radioactive iodine was used both to scan thyroids, and it was also used if you gave a larger dose, it was used to destroy a thyroid, especially any overactive parts.
Hmm.
So it was useful to treat people who had nodular thyroid disease if some of their nodules were so-called hot, meaning that some of their nodules were overproducing thyroid hormone. So that was the next advance. And pretty soon after that, we had a variety of nuclear medicine isotopes that were used for scanning. So you've probably heard of the term hot nodule and cold nodule, and it's still out there. Okay, after my entire career, I've been trying to stamp out that concept because it used to be thought that a hot nodule was benign. In other words, if it took up iodine, it was benign, and if a cold nodule was there, it didn't take up iodine on a scan, then it was malignant. And of course, we know that's not true, but it led to a lot of unnecessary thyroidectomies. And then the next advance also occurs around wartime, which is interesting. We hear that a lot of social changes occur around wartime, but sometimes medical changes do also. So you
Hmm.
remember the old World War II movies where there's a guy sitting down in a submarine and he's going ping, ping. He's trying to determine how far away the German sub is. Maybe you didn't watch any old World War II movies, but I grew up with those things. Anyway, that's ultrasound. Okay. They called it sonar, but it's ultrasound. So again, between the 40s and 50s and 60s, ultrasound was paired with computers so
Hmm.
that you could send out thousands or hundreds of thousands of pings all at once. And the rate at which they came back to you, bouncing off, in this case, body tissue, right? The
Right.
rate at which they came back to you could be converted into an image if you had a computer. So that's the next advance is that in the early 70s, we're starting to use ultrasound
Hmm.
to image. And of course, that's really helpful. And it still is a developing field, which
Hmm.
is extraordinarily useful in thyroid nodules because it helps us decide who needs a biopsy and who doesn't.
Right.
Okay. So, and then one more little story. Needle biopsies came into use in the 70s, which added another therapeutic and diagnostic, well, mostly diagnostic tool.
Hmm.
And this was invented in Sweden. There was the Karolinska Institute in Sweden is both a medical institute but also a veterinary institute. And there was this veterinary doctor named Torsten Lufhagen. So Torsten Lufhagen was a veterinary pathologist. So people would call up the school and they'd say, "Send out Dr. Lufhagen. Our horse has a nodule on his neck, and we need to know whether we should shoot the horse or not. We need to know whether the horse has cancer or not." So he went out and started putting needles into these nodules, and he'd bring the specimens home and put them under a microscope and try and determine what he knew about what the cells look like to determine whether it was cancer or not. So he'd call up the farmer and say, "No, I wouldn't shoot the horse," So
Oh my goodness.
so he was still teaching courses on needle biopsy in the East, and I went to one of his courses in 1983 at NYU. And
Wow.
I'll never forget that because he's basically the father of
Yeah.
thyroid nodule evaluation via
Wow.
fine needle. And now we're taking the specimens and not only sending them to look under the microscope, but we're
Hmm.
also checking them for genetic markers, molecular
Hmm.
genomic testing. So
Wow.
nowadays we come to where we have a much better ability to understand nodules before we actually do anything, right?
Hmm.
We can ultrasound them and determine which nodules need to be biopsied. And then the material we get out, we can look under the microscope, but we can also send it for molecular genomic testing. We can
Hmm.
even tell you if it is cancer, we can tell you what your prognosis is before we take it out.
Hmm.
Okay. So it's advanced pretty well during my career to this point where I'll look at somebody and I'll go, "Nah, that's not cancer. We don't even need a biopsy. Forget it." But if it's
Yeah.
bothering you, we'll do a biopsy before we do an RFA if you want an
Hmm.
RFA. And if you want
Hmm.
surgery, okay, we'll do the same. We'll do a biopsy just to make sure before you go for surgery.
I think it's interesting to see that progression from a historical perspective because I mean, a lot of people just assume this is just how we do things and they don't know the reasoning behind it or the history. I think you and I had this conversation in 2021 where you said that thyroid surgery is basically the same as it was 100 years ago and that it's not really changed since the way the Mayo brothers developed it. But all of these other things that you mentioned that came into play have changed the way we treat thyroid nodules. And one of those massive changes is the introduction of thermal ablation techniques like RFA. And so I
Yes.
think it's really great because we couldn't do RFA if we didn't have biopsies and ultrasounds.
Right. If we didn't know for sure it was benign, then
Mhm.
we wouldn't consider RFA most of
Yes.
the time. We wouldn't.
Yeah.
We can tell by ultrasound which one's the biopsy. And then after the biopsy results come back, occasionally you have to repeat them. You get
Mhm.
borderline results, but you basically know what you're dealing with. And that wasn't the case when I first started in medicine. You didn't
Mhm.
know it was cancer or not until you took it out. And that's important because only 4% of thyroid nodules are malignant. It's not very many.
No, it's not. It seems very much overkill if you can avoid the surgery by just determining what you're taking out before you take it out.
Absolutely.
Well, then let's talk a bit about then RFA. How does it work? How is it helping these thyroid nodules?
Okay, so the term radiofrequency ablation means exactly that, that you're using a form of radiation that has very long waves. It's the same radio waves that you get your music when you're listening to the radio, okay?
Mhm.
It's radio waves and they are emitted by antennas. So radio wave ablation needle is basically a little tiny radio antenna, okay?
Mhm.
You don't have to put a giant antenna on top of a hill.
Mhm.
You can make a small one. And so a needle that we use comes to a very fine point, and out of that point comes radio frequency ablation, which is just another form of electromagnetic radiation, just like X-rays and gamma rays and those things. But it's a low frequency, so when you focus it on a small area like the thyroid, it just creates heat. But it also creates electricity that goes through your body. So we put a couple of pads on your thighs, and those pads are so big that it spreads out the electricity so that it doesn't damage anything where it goes out of your body. When it goes into your body through the needle, it's focused. Okay. So you can control the area of damage. But after that, it transmits through your body and goes out through these big pads. So we have a complete circuit. You basically, you don't want direct current. You want, alternating current when you're doing this, right? Okay.
Mhm.
So,
Mhm.
so the radio frequency ablation basically consists of a box where the needle is hooked up to, and there's also a coolant. We can keep a bottle of frozen saline, and that goes through the machine also. There's a little pump because the tip of the needle tends to heat up.
Mhm.
So it's actually pretty noisy once we get going with an RFA, because you got the RFA ablation machine itself, and it talks to you. And
Mhm.
it says RFA on, RFA off,
Mhm.
and then you've got the pump, which makes a fair amount of noise. So we
Mhm.
do everything we can to keep the room quiet, and sometimes we'll even sedate the patient. Most of the time we do sedate the patient. So there's equipment that involves, like I said, the pads, the needle, machine to create the radio frequency, and a coolant pump with a bottle of saline. And it can be done in a fairly small room. The room that
Mhm.
we use at Dr. Leal's office is just barely big enough to accommodate the patient on a table.
And the patient comes in. I've been to your clinic and we've actually filmed a procedure. And which, if you're watching this interview and you want to see that, check the description box. There'll be a link to that video in the description, where the patient lies down on the table. You numb up their neck with lidocaine, and then you insert that probe into the nodule and essentially burn it. And why is that beneficial? What help does that do for the patient?
Okay, so we haven't really gotten to a thorough description of symptoms of nodules, but like I said, if they get big enough, and that usually means upwards of an inch, 2 inches for sure. If they're on the left side, they produce trouble swallowing because that's where your esophagus is. And that can be pretty irritating. A lot of these people, they can't swallow pills. All their
Yeah.
medications have to be either ground up or put as liquid.
Hmm.
And they also can't swallow pieces of bread or pieces of meat if it presses
Hmm.
on the esophagus. And then on either right or left side, if it's big enough, it can press on your trachea, and that causes a cough. And I see patients all the time, and they're like, "Oh, that's my allergies." And I'm like, "No, it isn't. I can see the nodule pressing on your trachea. It
Yeah.
feels like you have a chicken bone in your throat. Sometimes there are also positional changes, meaning if you lie a certain way at night, that nodule gets caught between the collarbone and the thyroid, and it presses on the thyroid, and you wake up and you have to roll on your side, or you have to lift your chin up or put your chin down. So it interferes with people's sleep.
Hmm.
And that's not even counting the fact that, if your nodule is a couple of centimeters, everybody you run into says, "What's that lump on your neck?" I
Right.
mean, it's just sort of obvious. So, so radio frequency ablation can relieve all those symptoms I just mentioned, in addition to the cosmetic concerns.
Hmm.
And does that answer your question?
Yeah, I want, for the patients who are watching this video who don't understand why you would burn a nodule, I just wanted them to understand that burning that tissue is essentially killing that tissue, right?
Essentially,
And
yes.
then the body has the ability to just reabsorb it, which causes it to shrink. And then that eliminates all those symptoms you were just describing.
I'm really glad you mentioned that, because my doctor focus is a little different than yours. And you're right. The patient perspective is, why would they want to cook something inside my body? Well,
Right.
basically, you can take the nodule out by cooking it slowly at just a slightly elevated temperature. And once it's cooked, your body recognizes that it's not alive, and your immune system will take it out piece by piece.
Hmm.
Okay, so that brings me to how is this different than regular surgery? So think about a Mayo Clinic thyroidectomy, and think about your thyroid as an orange.
Okay.
Okay, if you're going to do a Mayo Clinic style thyroidectomy, you have to peel the orange
Okay.
completely before you can get to the nodule, or before you can get to the thyroid. You have to peel it. And in
Hmm.
a living human, that means peeling away various neck muscles,
Mm.
nerves that are along the side of the thyroid gland, sometimes pushing what are called the parathyroid glands out of the way, which are also important. So basically, you have to peel everything away to get to the thyroid. And that, of course, it works, but
Hmm.
there's a lot of peeling going on. When you do a radio frequency ablation, you don't peel anything. Okay, you put an ultrasound probe on one side of the thyroid, and then you enter the needle on the other side, and you can see what you're doing from the inside.
Hmm.
So you never have to peel anything, and you can essentially cook the parts that you want to cook and get rid of those while you're watching it with ultrasound. So
Mhm.
it's hugely different. It's like the
Mhm.
difference between, say, the old timey when we would repair say a damaged meniscus on the knee. You'd have an open procedure where you'd have to, make a big incision and expose the knee
Mhm.
joint and fix it. And then we came in with arthroscope, guided surgery where you just put some fluid in the knee joint and you can extend the knee joint a little bit with that fluid so you can see what you're doing and just put a scope in. It's the same thing. Internal
Mhm.
entry versus external entry. And of course, the big
Mhm.
example of that is laparoscopic surgery for everything in the abdomen, spleen, gallbladder, colon, small intestine, whatever. And that
It's
really
minimally
limits
invasive.
that really limits the morbidity because these patients
Mm.
get up and walk home and they do whatever they want to do the next same day.
Right, right. Yeah. So they're not having to go under general anesthesia. They're not having to be recovering from that surgical incision, which, as you said, involves a lot of muscles. The neck, there's these strap muscles on the neck that are there's a lot more there than I think a lot of people realize. And when you cut through all of those all have to heal back together. They're affected by heavy lifting, straining, using the bathroom, any number of things affect those strap muscles in the neck. And so when you puncture those versus slice into all of them, there's a big difference in the recuperation time after the procedure. So we kind of went into the whole like procedure process and the comparison between RFA and surgery. What about using this procedure? How does it fit into the whole scheme of thyroid disease?
Well, I think that because it depends so much on ultrasound and the ultrasound guidance, that it limits this procedure to physicians and providers who are really, really good with ultrasound. So it adds a layer of expertise that you have to have. Again, to jump ahead a little bit, this is probably one of the limiting factors that has interfered with a more rapid adoption because in the
Mm-hmm.
past, all the thyroid surgery has been done by surgeons, and most are not actually doing ultrasounds. I know a few that are, but most of them they haven't done like thousands and thousands of ultrasounds on the neck. And until you're comfortable with that, having done thousands and thousands of them, it puts a slowdown in your application of this process. It's interesting that people in the United States who are really good with ultrasounds, who do them all the time, and
Mm-hmm.
again, I'm not excluding surgeons. I'd say that numerically, the people who do the most ultrasounds are generally radiologists and endocrinologists. So it's a shift in both the ideology of how you approach, but also a shift in the personnel that are available to do this. It fits in only in the fact that it's a disruptive technology.
Let's explain to the viewers what that means exactly, because I hear you say disruptive technology. I think something probably different than what the average patient might think. So
Right.
explain to me what you mean by that.
Okay. Well, it's a good thing we went over the Mayo Clinic brothers then, because the first my first definition of a disruptive technology is that it establishes a new norm for something that's been done almost exactly the same for 100 years.
Mhm.
Okay, that's pretty disruptive, and it
Mhm.
takes the healthcare system a long time to adapt to that. It's not necessarily possible to impose that on the people who are out there practicing. People have to come up with it during their training in order to be comfortable with it. So, uh, and anybody who's good at ultrasound can do this. Anybody, but you have to be really good at ultrasound. So that's the first thing. The other parts that are disruptive is, of course, it's radically different technically, like I said, with the orange metaphor,
Mhm.
in terms of how you do it. And then finally, it requires the patient to follow a different flow through the healthcare system. And
Right.
that's pretty disruptive too.
Mhm.
you know, our healthcare system has been sort of subdivided, and for years, a patient would go to a radiology department for a thyroid ultrasound or a scan. They'd go to an
Mhm.
endocrinologist if their levels were high or low, and they'd go to a surgeon if they were choking. This is disruptive because it basically says to us, look, if you want to maximize me being RFA, You need to go to a surgeon or you need to go to a physician who does all those things, who
Yeah.
scans, who treats abnormal high or low levels, and who can do the non-invasive procedures. It throws everything on its head.
Yes. Yes, it does. I can speak to that from my own personal experience
Yeah,
because
I really wanted to hear what you had to say about that.
so having been a patient who's undergone 2 RFAs and have had 6 years of follow-up, nearly 6 years of follow-up. Yes, I can say that it is very disruptive to the prescribed medical system of follow up for patients because I had to step outside of that system in order to even find the procedure, right? I didn't go to my local doctor and ask them, can you do radiofrequency ablation? Because it was not even discussed. It was not offered to me. I actually found it on my own through research and prayer. I will add that I was very adamantly begging God to show me something besides surgery, and I was able to discover RFA. But my local doctor was not informed on RFA. And so I went to another state and was treated outside of my normal medical team. And because of that, to have follow ups it also required me to step outside of that normal system of my local doctors because my local PCP, when I went to her for ultrasounds, the technician who did them at her clinic, while she had 30 years of experience doing ultrasound, she had no idea what to make of my RFA thyroid nodule that had been, altered by heat. And we can talk about why thyroid nodules look different after they've been treated with RFA in a minute, but she didn't know what to think of it. The radiologist who interpreted her ultrasound didn't know what to think of it. And so ultimately, the ultrasound proved to be completely unhelpful. And so I have continued to follow up with my doctor who's in Texas for almost all of my ultrasounds after my procedure. And that has proven to be the most helpful follow up because that shows he's able to look at my ultrasound and see, okay, I see what I did 6 years ago. I see that you are stable. I see that you've maintained a 90% reduction. Everything looks great. Versus when I go to the local imaging center who ultrasounds it and then sends it to a radiologist to interpret it, they think there's something really bad going on here.
Yes.
So yes, very disruptive. Unfortunately, we're not, even though it's been 6 years since RFA was FDA cleared in the United States, it's still not fully integrated into the system yet. So these patients are having to kind of step outside of that system, self-advocate, find doctors on their own if they're not lucky enough to live within a close proximity to one, and do that process on their own. And that is why I'll just give a quick plug to our community, Save Your Thyroid on Facebook, has been very helpful to a lot of patients who need help navigating that system that's kind of unknown territory, so to speak.
Yes, it is. And you feel kind of uncomfortable while you're doing it as
Yeah,
a patient. It's like,
completely.
am I
Yeah.
really doing what's best for me, or am I just going off on some kind of crazy tangent?
Right, right. Because
I
there's
predict that
this
if,
idea that if I'm going against what my doctor, who has all this experience and these degrees, is telling me, am I doing something that's not really respected and trusted by the medical community? And that's where we have to kind of advise patients with the knowledge that this has been done overseas for 20 years. There is a lot of
yeah,
clinical data to support the ablative technologies. It's
there's
just
a
that we're
ton of it.
slow to adopting. It takes something like 20 years for things to new technologies to get fully integrated into medical practice, right? Something along those lines.
Well, I've not heard that particular number, but just to add emphasis to your discussion, Dr. Beck did his first RFA in like 1998,
Mhm.
before the
Right.
millennium. I mean, holy cow, we're coming up on 30 years
Yeah.
in a couple more years.
Mhm.
But you have to remember that the system we have a big healthcare system. It makes a lot of money, and it's been designed to depend on a Mayo Clinic style thyroidectomy for 100 years. And the expertise that's out there in most people who operate is the Mayo Clinic. I mean, I have to be fair. I'm not here to beat up on surgeons. They have made improvements. We now have endotracheal tubes that have electrodes on them, so that if you touch one of the nerves while you're operating, it'll notify you. So that's definitely a big improvement over a
Mm-hmm.
Mayo Clinic style operation without the endotracheal tube that's got the electrodes. In other words, if you touch a nerve in your neck, it'll show up on a little screen.
Mm-hmm.
And of course, the more operations of the Mayo Clinic style that a surgeon does, the fewer complications they have.
Right.
But the average, I just want to mention this because I think we haven't gotten to this safety part. But unless you're just a real klutz with your hands, it's hard to damage a patient with a radiofrequency because you're inside the nodule. You're
Mm-hmm.
working inside the nodule, right? So you're not touching or even near any of all these structures that you've mentioned, like the 6 strap muscles and also the 3 important nerves, the vagus nerve, the
Mm-hmm.
phrenic nerve, and some other nerves that go down into your chest,
Mm-hmm.
and even sensory nerves.
Mm-hmm.
But even the best surgeons who do the Mayo Clinic style open thyroidectomy, they still have a pretty serious complication rate of 1 to 2%. Okay. And you just don't see that in RFA. There are occasionally case reports, but it's pretty clear when you see those that somebody wasn't doing the RFA properly, that they were going too far, too close to the capsule of the thyroid. So I think it's inherently very safe. Of course, you have to know what you're doing.
Right. Right. And I think one of the biggest advantages that we haven't discussed yet is this lifelong dependence on thyroid hormone that is required after you remove the thyroid gland. That is not present after treating a thyroid nodule with radiofrequency. And I would love to hear your thoughts on that as an endocrinologist with as much experience as you have managing thyroid patients on thyroid hormones.
It's difficult to avoid thyroid hormone replacement after surgery unless you have at least 50% of your thyroid left. Okay?
Mm-hmm.
And that's just kind of a number that keeps popping up. For some people, it's 40%. For some people, it's 60%. But having seen so many people get thyroidectomies, once somebody takes out one lobe in the isthmus, I'm pretty sure they're going to be on a thyroid hormone. And
Mm-hmm.
that's a lifelong dependency. Means you have to have your levels checked probably once a year when you're younger, but as you get older, twice a year is better because your thyroid hormone requirements change as your metabolism slows down in your 50s and 60s and 70s. So it's a lifelong dependency. So you're probably not going to need thyroid hormone unless you have another thyroid condition, one of those autoimmune things I was talking about. But there's another angle to this too, and that is, let's say you have nodules on both sides. Even if you leave in 15% and you had to operate and take nodules out on both sides, even if you leave in 15%, the little part in the middle or an upper lobe, it makes adjusting your thyroid hormone level so much easier because you've still got a little personal factory in there that's adding to your
Right.
thyroid hormone. It's when you're completely 100% deficient in thyroid hormone that it gets extremely difficult to manage this. I'd say fully 30 to 50% of the patients I see who've had total thyroidectomies, they're just never happy. They're cold all the time, and it doesn't matter what kind of adjustments we make. It's hard to fix that. You're
Yeah.
better because if nothing else, you need that extra 10 or 15% that your body makes in the wintertime when it's cold. And if your thyroid is 100% gone, you're not going to have
Yeah.
that. So you're going to be cold in the winter and probably hot in the summer. So
Mm-hmm.
let's have a plug for Save Your Thyroid. At least save the good parts.
Yes.
Save the good parts. So don't do a total thyroidectomy just because the patient has a little nodule on the relatively good looking side. You can monitor it, and if it starts to grow, you can do an RFA on it. So let's say you're a person who has a big nodule on one side and you decide, well, this is just, I just want to get it out. Okay. And
Mm-hmm.
you have a couple little ones on the other side. The rational way to approach this is, if you want surgery, have the big nodule side taken out. Maybe biopsy the little ones on the other side before the surgery, and if they're benign, monitor them. if they start to grow, then do an RFA before they get so big that they crowd out your thyroid function.
Yep.
That's the way I would approach it.
I completely agree. And then even some patients, we know a lot of patients who've had, myself included, who had a really big nodule and treated it with RFA, and then all of their smaller nodules have just been monitored, and if they're stable, leave them alone, monitor them annually or every 6 months. And this is a topic we were going to discuss, was multinodular goiter, or like you said earlier in the discussion, nodular disease is a chronic disease, and how that's something that we have to continually monitor. And I believe you were going to discuss those nodules, making sure that they're not growing. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation. So do you want to move into that topic now?
Sure. Yeah. My favorite topic of all.
Okay.
What are the techniques and conclusions you have to make in order to leave in some good thyroid? And the first thing is to think of a nodular thyroid disease as a chronic disease, because patients usually have nodules on both sides. Okay, they usually do. If you have one nodule on one side, you're pretty lucky. That's because the conditions that lead to thyroid nodules are usually going to affect both sides and the little part in the middle called the isthmus. And those conditions that lead to nodules are genetics. You often inherit this. Radiation exposure, iodine deficiency during childhood. Sometimes pregnancy seems to initiate this. So anyway, the conditions that cause thyroid nodules affect both sides. So the first thing is to recognize this is probably going to happen on both sides, even if the patient only has a nodule on one side right now. We know that 96% of thyroid nodules are benign, but we also know we don't want to miss that 4 to 5% that are malignant. When I say think of it as a chronic disease, let's give a couple examples. Like, let's say you have ulcerative colitis. You're going to see a gastroenterologist, right? He's going to monitor some blood work and occasionally do some imaging or maybe do a scope. And he's skilled at determining when it looks like it's getting worse, right, and when an intervention is necessary. And he'll time his intervention so that the aggressive intervention is when you need an aggressive intervention. And the milder intervention is what you need when the disease has a milder state of activity. Same thing with, say, rheumatoid arthritis. You're going to see a rheumatologist, and he's got all these tools to monitor how severely it is developing. And also the patients tell him, well, it's moved from my ankle to my knee, and my knee is really important because my other knee is bad. So you have a chronic disease who's a subspecialist, all right? I like to make a case that you have a chronic, whether you want to call it a disease or a condition or an illness, nodular thyroid disease requires monitoring like that.
Absolutely.
And our system isn't very good at setting up patients and hooking them up with a person who can monitor their conditions. It's just, people change insurance too often, and they move, and then sometimes they run out of insurance. So our system doesn't really facilitate that. But if you're one of the lucky ones that has insurance that's not changing all the time, it's best to think of nodular thyroid disease as a chronic condition, because your nodules have a good chance of growing. It turns out that after 10 years, somewhere in the range of 30 to 40% of nodules will have grown. They don't grow quickly, right? Which makes it difficult, because you tell somebody to come back in 2 or 3 years, and they're like, heck, I'm not even going to know what your name is in 2 or 3 years. How am I going to find you? Mm-hmm. So we're sort of stuck with annual monitoring. Mm-hmm. But I think you have to monitor somebody for at least 10 years before you can tell them that their nodules aren't growing. And then the other thing is, RFA is much better done on a nodule that's not too big. The bigger the nodule is, the harder it is to treat because you have to turn people's neck a certain way to expose a part of the nodule. You might have to lift their chin up. So a really, really big nodule is harder to do an RFA on. But
Mm-hmm.
say a 2 centimeter nodule, you come back in a year and it's 2.5 centimeters. Maybe you wait another year. You come back and it's 3 centimeters. You can say, look, this is going to grow. It's right at the juncture where it's going to start causing cough.
Mm-hmm.
So this is the time to do an RFA. If we wait
Right.
until you have a big mass in your neck, it's much harder to do an RFA on a really giant mass because it changes the anatomy. It moves everything around if it's really big. So,
Yeah.
so the best application of RFA is like somebody can tell you because they've treated you as a chronic condition, this thing is growing. Now's the best time to do RFA. The complication rate is 0, and we can pretty much eliminate that nodule because it's not huge.
Yeah. The bigger a nodule is, the less percentage of reduction you'll expect. With mine, it was between 65 and 75 milliliters, and it shrank 90%. And that was unbelievably good because we were not expecting that. We were not
Yeah, that's
expecting that at all.
yeah, that's
Yeah, we
really
were
good for a
expecting
big nodule.
50, right,
I'd
right.
like
We were expecting 50, 60%. So,
I've had to satisfy myself with just shrinking big nodules and being happy with 50 to 75% most of the time because
mhm,
most of my exposure to this has been when insurance wasn't covering it. So we had to give patients one treatment because they couldn't afford 2 treatments. So
mhm.
we would just do as much as we could. But surprisingly, shrinking a nodule by 50% makes a huge difference.
Huge difference.
Yeah, most of the time the symptoms are gone. You might still be able to see a lump in the neck, but they reach a critical point where the symptoms are very bothersome and you don't have to shrink it. So we're not really getting rid of nodules, we're just controlling them most
Right,
of the
right.
time. Now, the
Yeah,
small ones, I'd love to have more of those small ones that I could just get rid
yeah.
of.
That's actually, I'm glad you brought that point up because that's a question we see a lot in the community from patients is this going to get rid of my nodule, totally eliminate it? And we have to explain to them, no, it won't completely eliminate it. Most likely, it will just shrink it to a point where it's no longer going to bother you. Now, the exception to that is if you're treating these very small nodules, like you were just describing, where it's small enough that when it does reduce, it's going to reduce so much that you basically won't be able to see it anymore. But my nodule is still there. I still have a 6 milliliter remnant left behind in my neck. But I just literally went for a doctor's appointment last week, and the doctor felt of my neck. She's like, I can't feel anything in your neck. I have a nodule here. I have a couple nodules here. Couldn't feel a thing. So it's important for patients to understand getting rid of the nodule isn't necessarily a requirement for benign nodule. It is if you're treating a malignancy, and that's a completely different scenario, one that's kind of outside of our discussion today. But I have some other episodes about that topic if anyone watching is interested in that. But let's circle back to we talked a moment ago about the follow-up aspect and how these nodules change somewhat on ultrasound after the procedure. And I kind of alluded to that with my experience with follow-up. Can you explain what's happened to these nodules, why they look different on ultrasound, and why, if someone who is not trained in this procedure is evaluating that ultrasound, they may panic a little bit when they see those changes?
Yeah, my experience on the follow up is that it's hard to predict what it's going to look like. Sometimes, if you happen to have ablated the blood vessels that go to the nodule, just for an example, and then you do a follow up later, sometimes the nodule is gone. Okay.
Wow.
I mean, it just disappears. And
Mm.
Louisa Leal and I have seen a couple of those that we did. Often we did them like there was a big one and a small one on one side, and we did the big one, the small one, and the small one completely disappeared.
Wow.
Unfortunately, unfortunately, you're right about that. Generally speaking, it's not going to disappear. But
Mhm.
when you do a big nodule, you always leave a little bit of the nodule. So you end up with a normal kind of rim, again, back to our maybe using our orange metaphor, right? You still have the peel, although it's markedly reduced. But then in the middle of that peel, you have a lot of scar tissue, which refracts and reflects the ultrasound beam, and
Mhm.
so it sometimes looks a lot worse than it is, because when you damage thyroid tissue, what's left in there is a scar, which is pretty dense. And
Mm-hmm.
the ultrasound waves bounce off it, sometimes going in a lot of directions. And
Mm-hmm.
like you said, it looks weird to somebody. And
Right.
the rule of thumb is if you see something that looks weird in the thyroid, you better be concerned. So
Right.
I can't blame them. We don't really have yet a lexicon of ultrasound appearances after RFA. That's one of the things that we need,
Yes.
that hoping some of the organizations will get together. Patients, if we go to centers where hundreds or even thousands of RFAs have been done, somebody could collate these and say, okay, these are the most common appearances of a nodule after an RFA. This one is concerning. These aren't. We have
Mhm.
that for nodules pre-RFA. There's no reason we can't develop that for nodules post-RFA. Somebody just has to get together and collate some data.
I
So
cannot wait
yeah, it's
for that
pretty
to
scary.
happen.
So I
Yeah.
wouldn't go have an ultrasound anywhere after an RFA unless it's done by somebody who actually does RFA.
100% agree. And that is exactly what we tell patients in our community. Find someone who does these procedures, even if it's not the person who did your procedure. If you're living somewhere where there's a physician who maybe does the procedure now that didn't back when you had yours done, go to them for your follow-up. I know so many of these doctors would be happy to follow up with you even though they didn't do your procedure, because they're going to understand better what they're looking at than someone who's never done or seen an RFA treated nodule. That's really important. Patients after they have RFA generally don't need thyroid hormone, which is a
Uh,
huge advantage.
you can fault me for not mentioning that. Yeah, I kept talking about what happens with surgery, but I didn't mention RFA. Yes, if you do an RFA on one side of the thyroid and the other side is not got any medical conditions that would damage it,
Mhm.
then you're probably not going to need thyroid hormone. Right,
Which is hugely helpful to those patients like you said who they still have their thyroid function. Even if they do need a little bit, it's better
right,
than having to completely replace it.
right. There's a gradation there. Like
Mhm.
even if you had RFA of a big nodule on both sides, which you
Mhm.
wouldn't do at one sitting, you'd have to do it two
Right.
different procedures. But even if you did that, the chances are if you had to take thyroid hormone, it wouldn't be very much. You'd be producing most of it on your own, which I can't
Mhm.
emphasize that enough. Your thyroid
Mhm.
doesn't produce the same amount of thyroid hormone every day. It depends on how much you're eating, how much you weigh at
Right.
that point, how much you're exercising regularly, and the
Mhm.
season. Okay. And it's kind of hard to keep up with that if you have to do
Yeah.
it by a pill. You can't do it. So it's really nice to have just a little nub of thyroid in there to do what I
Mhm.
call the fine tuning.
I love that analogy of the you mentioned this in a previous conversation we had. You talked about a glass, pouring the water into the glass that's already part of the way full versus a glass that's completely empty. And I think another time we talked about it, you said it was kind of like a bicycle going up a hill with, a little bit of an extra push. That's like if you already have a little bit of thyroid in there, but if you don't, it's like you're at the bottom of this steep hill and you have nothing to help you get going over the hill. So,
You have
very
to sit there
important.
and wait until your thyroid pill takes effect.
Right. Right. So I want to just add this little thing to this conversation here. It's so I about a year ago actually learned that my thyroid was a little bit low. And it's the first time it's ever been low out of, this entire 10 plus year journey that I've had thyroid nodules. And I've been in perimenopause for the past year and a half, 2 years. So I started having to take just a tiny little dose of T3 because all of my T4 levels were normal. My TSH was normal, but my T3 was low. And it's a tiny little dose that I have to take. And just that tiny little dose is all I need to be able to think clearly, for my hair to keep growing, everything else to keep working properly. And I think that it's important for me to mention that started, like I said, about a year ago, and I had my RFA 6 years ago. And I think that it's pretty clear and I would love to hear your thoughts on this. For patients who do have hypothyroidism after RFA, it generally happens pretty soon after the procedure. Is that correct?
Yes. I would say within 6 to 12 months. You kind of fit the profile of somebody who might have a little autoimmune thyroid disease too. My experience is that something about menopause seems to precipitate a little bit of Hashimoto's in everybody. And
Hmm.
sometimes it lasts and you end up on thyroid hormone, and sometimes it goes away. But there's something about a drop in the estrogen level. We see this
Hmm.
after pregnancy too.
Hmm.
There's something about a drop in the estrogen level that seems to get your immune system saying, huh, I'm going to go after the thyroid now.
Hmm.
So the majority of people that you see who are diagnosed with hypothyroidism are 52 or 53 or 54. It's pretty
Okay.
consistent. So it's probably
Wow.
a little bit of Hashimoto's. You know, we don't want to talk too much about your particular problem, but I don't think you've had enough RFA to do it. And also, it
Yeah.
should have happened within a year after you had your RFA. So you might
Right.
have what
Right.
I call you might have what I call double damage. You know, RFA
Okay.
and a little Hashimoto's.
Yeah, well, and that was actually something the reason I mentioned it in this context is because of the fact that when I first was diagnosed, it was a concern of mine that people might think, I see she's got hypothyroidism because she had that RFA, and I wanted to kind of fully absorb everything there was to know about why hypothyroidism does develop in a small number of patients after RFA. And most of what I learned indicated that or pointed to that Hashimoto's already was in existence with that patient at the time of the procedure. So the thyroid function was already reduced capacity at that point anyway. And then just as, they were eliminating some of that nodule, it went down. So, but that wasn't the case for me. So yeah, I take these teeny tiny little, they're so tiny. These itty bitty pills 3 times a day, just 5 micrograms of T3. And it made a world of a difference for me because I was really tired. I was to the level I was having trouble with the podcast, doing all the things that I do. I couldn't keep up. I didn't have any brain power. And so adding that in made a big difference for me.
I know this is not the subject of this conversation, but I bet if we had opened this up for questions, there'd be a lot of questions about T3. So I just
Probably
have one
so.
thing I want to say about T3. Okay.
Okay.
T3 is a very powerful thyroid hormone because it is the thyroid hormone.
Right.
T4 is a precursor. By itself, it does nothing. T4 has to be converted to T3, which is why people who've had a total thyroidectomy don't do very well because your thyroid gland is the main organ that converts T4 to T3. Anyway, if you're somebody who's taking T3, you have to spread it out in order to avoid side effects.
That's right.
Somebody taking 15 once a day is going to feel terrible, whereas
Hmm.
somebody taking 5 2 or 3 times a day is going to feel just fine. And you'd think, well, it's the same dose, but it's easy to overdo on your T3, which is why it's very tricky to use things like Armour thyroid because it's some of those doses of Armour thyroid, they have too much T3 in them.
Hmm.
T3 must be spread out over the day, and then it works great.
That's exactly me. I take one dose in the morning, one dose in the afternoon, and one dose right before dinner, and tremendously helpful for me.
Yep.
Very grateful
Yep.
for T3. So, okay, let's get into. We've talked a little bit about the patient experience where the patient has had local anesthetic, so the procedure's not painful. And we've talked a little bit about the recovery. Let's talk about candidacy for the procedure because we've not really covered that yet. So, patients who have thyroid nodules, obviously, we're talking about that. We're not talking about patients with just total Graves' disease where their entire thyroid is overproducing. So, talk about the candidacy for those thyroid nodules for treatment with RF.
And I'm going to start by bringing up the item that you mentioned, which is the concept of what represents a thyroid nodule that's a candidate for RFA has evolved a little bit. It
Mm-hmm.
used to be thought that they had to be sort of small nodules, but
Mm-hmm.
now we're looking at RFA as a total treatment for nodular thyroid disease, regardless how many nodules you have or how many treatments it requires, and
Mm-hmm.
including big nodules.
Mm-hmm.
So we have a technology here with RFA that can pretty much deal with any size and any number of nodules. So that's no longer an exclusion, although it used to be thought that. And I still know physicians who say that that nodule is too big for RFA. And I'm like, oh, no, it isn't. It's just, it takes a long time to do a big nodule. So you do it, you wait 3 to 6 months and you go back and
Mm-hmm.
you finish it up. All right. But some of the other reasons that are in existence for a good candidate for RFA is the nodule should be mostly solid. And we didn't even talk about that, but a lot of nodules as they age become cystic. They fill up with fluid. So if they're more than 50% cystic, we wouldn't do an RFA first because the radiofrequency doesn't, there's nothing to destroy if it's mostly fluid, right? There's another way to get rid of that fluid. But so anyway, mostly cystic nodule is not a candidate, but a mostly solid nodule is always a candidate regardless of the size. I like to look to see if I can document growth before I'll do a small one. A big one, you don't need to document growth. A person's choking,
Right.
can't swallow. But a smaller one, like in the range of 2 to 4 centimeter, I like to see that there's documented growth. I think that's a good reason. It helps you explain to the patient why they need to have it now. We need to have a documented negative biopsy for cancer. That's an absolute. You just have to know. Then it's helpful. A good candidate is somebody who has symptoms or somebody who doesn't like the way it looks.
Right.
The symptoms we mentioned earlier, I think a cosmetic concern, especially if it's high up in the thyroid, every time somebody looks at you, they see that and they, it's just bothersome. So those are good candidates. And then patients who aren't good candidates, I've got a little list I'm going to read off here. Of course, we're not treating thyroid cancer, small thyroid cancers with RFA in the United States yet, but it's already a big deal in Korea and China and Japan. So it'll get here eventually if there's a small thyroid cancer, but not right now. If the nodule is big enough that it goes down into your chest, you probably are not a candidate for RFA because you can't get to that part.
Right.
Breastbone and the collarbone are in the way and you can't see that part of the nodule with your ultrasound. Somebody who's had a lot of surgery on their neck and has a stiff neck from all kinds of arthritis surgery, very tough to do an RFA on them. Of course, it's also tough to do a thyroidectomy, but it's painful to move your chin up or to the side if you've had a lot of surgeries back here. So I would contend that an immobile neck, because most of these patients we're doing them while they're awake, We don't want them to be in pain from something else. I think morbid obesity is a relative contraindication because your ultrasound probe only, can see down to about 5 centimeters. If you have a big fat layer here, you can't see what you're doing. You don't get the optimum visualization. And, patient preference is still as important. Some people just want to have RFA, and I'm like, okay, we'll try it. Or some people just want to go to surgery, and I'll say, okay, that's okay too. But let's leave the good side in. Okay. You have on your list, does RFA hurt? So once you get to the procedure, no, RFA does not hurt. You can explain that probably even better than I can, but the doctor who does it has to learn how to put the anesthetic in a certain location. It has to be in that spot. And it's what's called the false capsule, which is sort of a layer around the thyroid, between the thyroid and the strap muscles. But if you get it in there, the thyroid is completely numb. And with big nodules, we have to put it in twice. With small nodules, we put it in once. And if that's done properly, you can actually see the local anesthetic coursing around the thyroid and goes from the front all the way around to the side. And you're like, okay, that's good. We're going to be numb. And that's, just a technical thing. But the only thing the patient will experience if you do the anesthetic right is a popping sound. It sounds like little tiny popcorn things being made in your neck. You hear this little, doesn't hurt though. It doesn't hurt.
It's just strange. And it the first time you hear it, if you're not expecting it, it can be a little unnerving. But my doctor said to me, don't worry, that means it's working. So I was kind of like, oh, it's a celebratory thing, let's be happy that we have popping. And regarding the anesthesia part, I wanted to just add to what you were saying that yes, it is incredibly effective when that anesthetic is placed in the right location. You will not feel any pain. I had no idea my doctor had started ablating, and he asked me how I was doing. We were 30 minutes into the procedure, and I said, I was waiting for you to get started. I didn't have any idea that you were even working. And he said, oh yeah, we've been working for about half an hour. Yeah, that anesthesia worked. I mean, it was just local lidocaine, it did not hurt at all. There were moments where it did, and that was an indication to my doctor that, maybe we needed to adjust, or, my procedure did last a long time. We did, like you said, have to do additional lidocaine, but in general, not painful at all during the
I think
procedure.
if you go past about 25 minutes, you have to put another injection of lidocaine in.
Well, and
You have to keep
speaking
an
of,
eye on how much you're using too. You can't use more than about 25 cc's at any one sitting.
I think that's a good segue into the conversation on insurance. You touched on this earlier. And we do have a code, a CPT billing code as of January 1st, 2025 for radiofrequency ablation of thyroid nodules. But it's not all sunshine and roses. There are some limitations for that code. So why don't you kind of share some of your experience that you've been doing this procedure before the code and now since the code was adopted?
The RFA is sort of expensive overhead wise. We use up probably $2,500 worth of stuff.
Mm-hmm.
Okay. If you count all the xylocaine, if you count all the sterile gowns that we have to throw out after the procedure, those are expensive. All the sterile towels we put around the neck, the financing cost on the machine, a lot of people do lease purchase on those. So there's
Mm-hmm.
a financing cost on that. You have to have an ultrasound machine. Those are 25,000 minimum, sometimes a lot more. There's a
Mm-hmm.
financing cost on that.
Mm-hmm.
You have to have a good table that moves up and down and tips. Those are 5,000. You might have a financing cost on that.
Mm-hmm.
And then the needle itself is almost $1,500.
Mm-hmm.
Just the needle. And you
Right.
have to throw that out when you're done.
Mm-hmm.
So we're out of pocket. We're spending 2,500, maybe even more if the patient has a large nodule, because we also have that saline, which is the coolant. And you
Mm-hmm.
might go through 2 or 3 bags of saline. And of course, when you have a big nodule, that means that the personnel time is longer.
Right.
We're in there a lot longer. I mean, some of the biggest nodules, Louisa and I have been working in there for an hour and a half or 2 hours.
Mm-hmm.
You have to. So if Medicare pays you $2,900, that's the current CPT code. Okay,
Mm-hmm.
and you spent between 2,300 and 2,500
Mm-hmm.
just to get to the point to be able to do the RFA, and then
Yeah.
you have to pay Dr. Louisa and Dr. John to do the procedure. Well, you're behind.
Mm-hmm.
And I mean, we can't do it for free. We have to
Of
pay our
course.
overhead. We have to pay our rent.
Right.
So most of the people who were doing this before the CPT code were charging about twice what Medicare pays. Okay,
Mm-hmm.
which I think is fair. Of course, it's hard for patients to come up with that much money.
Sure.
A lot of us had to develop payment plans.
Right.
But the number one complaint about this is actually not the amount. It's the fact that the Medicare rule will pay hospitals for all this extra overhead. They actually give them a separate fee called a facilities fee, which pays for the room and the equipment and the debt service on the equipment and the table and the anesthesiologist and the circulating nurse. So they get an extra big chunk above 2,900. And
Wow.
when we do it in an office, which one of the major benefits of this is it's low cost, right?
Right.
But we don't get that facility fee. It's zero. So
Yeah.
we have to get the patient to make up for that difference. And that has really upset a lot of people, because we took a simple procedure that you could do with a local anesthetic, and now we're shifting it to a more expensive place that actually they can't do it inexpensively. They've got
Yeah.
many more personnel involved. They're in the high rent district, and suddenly the RFA is costing twice as much, maybe even more than that. And it shifts the care away from my ideal concept, which is to have the RFA, the follow-up blood work, the follow-up ultrasounds all done in one place, so that
Mm-hmm.
you have continuity.
Yes.
So we deserve a facility fee for the same
Yeah.
reason.
Yeah, I think
Okay.
that the way the code was written, like all of the requirements for the code, with all due respect to the people who wrote it, I feel like it was just not, there was not enough information that was understood by those people to very adequately compensate the physicians who are doing these procedures in all the different settings. You
Right,
know,
and including the setting of the nodule. We should have different codes for different sizes of nodules.
I
Okay?
agree. I agree.
The surgeons have a different code for a laparoscopic cholecystectomy versus an open cholecystectomy because one takes
Mhm.
so much longer. We should have at least 3 different payment levels for the size of the nodule so that once you get started, you can finish on a big nodule without losing without.
Yeah.
So yeah, you're absolutely right. I don't think there was a lot of, well, I don't know. I wasn't in on those discussions, but a wise person once told me there's science and then there's politics. And when you try and mix science with politics, you just get politics.
Mm. Yeah, and without going into a discussion of politics, I think that we're just going to have to wait and see, and maybe things will shift. With time, things might be adapted or adjusted with the coding and the wording and the rules associated with it. We're just going to have to see how it plays out. I've not really commented on it tremendously publicly because I've asked a lot of doctors what their experience has been, and it's been so different with every doctor, with every facility, with every insurance company. It's different across the board. So we really don't know a whole lot yet as to how it's all going to play out in the long run. But I still think it's worthwhile for patients to consider it, whether it's out of pocket or whether it's insurance, or whether, when you're comparing the cost out of pocket for an RFA versus a thyroidectomy, the cost out of pocket is going to hands down be lower for the RFA, regardless of, whether you have insurance coverage or not. It will be cheaper in the long run,
Even
because
at a hospital.
I believe so, because you have to consider every time someone has a surgery, there's always going to be out of pocket costs that you can't see coming. I mean, think about, you go to the hospital and you have something done. It's never going to be the out the door cost that you anticipate. There's always going to be a bill that comes later. There's always going to be an extra add on that you're not anticipating. And then there's also, with the thyroidectomy, you've got the follow ups, you've got the medications. You know, it's going to add up. And I would love to see, I've said this before, someone to do a cost benefit analysis on surgery versus RFA and compare which one comes down to the largest out of pocket expense. Because I think a lot of people falsely assume that if thyroidectomy is covered by insurance, it's less expensive. And I just don't think that's the case.
Right, right. I would, for my part on this, I'm never going to do this in a hospital because I had to learn, to do it in a clinic, and I'm perfectly comfortable with it. I'd be happy with just a simple change in the reimbursement, which is that Medicare and insurance would pay for the needle, you know,
Mm-hmm.
and maybe give us an extra 400 or 500 for all the equipment that we have to use and all the stuff we have to use and throw away.
Yeah.
If they could get it up to if they could get it up to 5,000, I think people would be, and physicians would be, as well as patients would be more likely to do it in the outpatient setting because it's just so minimal. Everybody just The only complaint we get is on a big nodule, we're about 2/3 of the way done, and the patient will say, "I have to go to the bathroom." So we've solved that by making them go pee right before we start the procedure.
Right?
But when they're done, they're like, "Oh, you mean you're finished? Oh, I mean I'm going home? Yeah, you're done.
Yeah.
Yeah." And of course, that's so much better than a thyroidectomy. It's really incredible. And we haven't even talked
Mm-hmm.
about the fact that even if you aren't comparing it in terms of dollars and cents, the amount of suffering and those people that 3% of people who've had the thyroidectomy complications, it's huge. Those complications never go away. That's lifelong treatment for low calcium and sometimes lifelong hoarseness. And you can argue about whether it's 1 or 2% or 3%, but even, 1 out of 50
Yeah.
is a scary number for a permanent complication. And we just don't see any of those voice or calcium related complications with RFA. None.
Quality of life is vastly important. And I think that that is what's driving patients to pursue RFA and other non-surgical techniques is the fact that they have seen the horror stories that do exist in the online forums, such as Facebook groups, and patients know people who have undergone thyroidectomy. And, I saw recently from another surgeon that I know who's on social media who said most thyroid surgery that's done in the United States is done by low volume surgeons that do like 5 thyroidectomies or less a year, which is absolutely terrifying to think about because if you want a good outcome in any procedure, you want a surgeon or a physician, whoever's doing your whatever procedure, you want them to be highly skilled in that. You want them to
Yeah,
have a lot of practice. You don't
yeah.
want someone who does it 5 times a year. And
We have a
so,
number for that actually. Once a week. If you're not
yeah,
in somebody's neck once a week, I'm going to
yeah,
find somebody else.
yeah. And
Yeah.
so the quality of life issue is really a big deal because these patients that are having these problems, it's probably because they had a low volume surgeon and then they have an endocrinologist who's not really experienced with adequately managing their hypothyroidism afterwards. So
Yeah, I think there's a lot of resistance to using T3, to your
I
point.
agree.
And even among endocrinologists, there's a lot of resistance to using T3. And
Mhm.
we need to loosen that up a little bit too. That hasn't changed in 100 years either.
Well, maybe we can have another discussion about that because I think that's a topic worth covering but it'll be a whole other episode.
Yes,
So,
agreed.
yeah, quality of life preservation is key here. And I think that that is what's changing the landscape of non-surgical interventions on thyroid. That's why it's becoming so popular. Do you have any final thoughts on this evolving landscape of patient care for dealing with thyroid nodules without surgery?
I would just like to conclude with a couple of comments. One is if you think you want to pursue RFA, you have to remember you're still swimming against the current. So you have to be willing to understand that and move with it and sort of push against the wall, so to speak, to get what you want. And
Totally
if you
agree.
have thyroid nodules, even if you don't think you need an RFA or surgery, there's so many people out there with thyroid nodules.
Mhm.
Find a specialist who does ultrasounds in their own office. Get set up with a chronic disease management plan. And the best way to do that is to find a physician who does his or her own ultrasounds. And there are lots of them out there. And then they can help you with that issue, whether the nodule's growing, whether it needs a biopsy or not, whether it's time for an RFA or whether you need a molecular genetic test before you go for an RFA. But get somebody who's a specialist who's kind of got it all rolled together. Try and avoid disjointed care as much as you can, even if it requires travel. I knew you'd agree with that.
Very important. I mean, continuity of care, we touched on it earlier. Continuity of care is a big frustration when you don't have it. When you're dealing with you're bouncing from one doctor to another to constantly try to manage your disease. And so I fully agree with your statement about finding a specialist that can help you with all of this all in one place. Where do you see thyroid RFA going in the future? Do you think it'll ever replace surgery?
I think we will first and most importantly see RFA clinics. It may take a little while, but I think we'll see physicians and nurse practitioners and radiologists working in what's called an RFA clinic, or they might work in a thyroid ablation clinic where they're going to incorporate maybe some of the other ablation technologies, high frequency focused ultrasound, there's laser, a bunch of other ones that are in use in other countries. So
Mhm.
I think that will eventually develop and you'll be able to go to a place and get everything at once because it's efficient. It'll take the payment system a long time to catch up to the fact that efficiency boils down to having everything you need in one place, but they'll
Mhm.
eventually catch up. And then I think ablative technologies will probably eliminate 95% of thyroidectomies done for benign thyroid disease, for nodular thyroid disease. It won't eliminate 100%. And here's why. Sometimes nodules get so big that they distort the anatomy. And when you distort the anatomy as much as a big nodule can, then you can't see everything on ultrasound and can actually see it better if you're operating. This
Right.
is especially true for the carotid sheath, which is a little sort of a tube that goes along the side of the thyroid that has your carotid artery and your internal jugular vein and your vagus nerve. And those three structures are usually in sort of a normal orientation to each other, where the carotid is closest to the thyroid and the vagus nerve is the one that's farthest away. Okay. If you get nodules that are big enough, they tend to flatten that little tube out a little bit and push the vagus nerve closer to the thyroid. So when you have a really, really big nodule, it's hard to see the margins of where the normal thyroid used to be, and you know you're up near the vagus nerve. So we'll always need some thyroidectomies. And I think it will also replace surgery for small thyroid cancers that are less than 1.5 centimeters. It's also going to find some use in treating metastatic thyroid cancer. People who have either papillary cancer, which is the most common form, or medullary cancer, which is a more rare form. But those two tend to spread locally. And if every time the cancer recurs, you go in and take out a couple of lymph nodes, you're going to damage the nerves in the neck for sure, because your neck can only tolerate really one operation. The second and the third one, they're really high risk, those second and third thyroidectomies. So RFA will play a role in ablating metastatic lymph nodes for papillary and medullary carcinoma too. I even saw a report today where somebody was using it on a skin metastasis from a papillary carcinoma.
Wow. I've never heard
Anything
of
that can
that.
be, anything can be imaged with ultrasound is a candidate for, an ablative technology. So that's where I think it's going. I probably won't be there, but that's all right.
You have given me so much wisdom and knowledge today. I can't thank you enough. I can't wait for the next time for us to chat more on all these topics.
Well, I have thoroughly enjoyed it. So thank you very much for allowing me to do this.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There, you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.